Well, welcome to our first CLaN session for 2025. It's great to see so many people here, and I know more will be joining us as we progress. So welcome to this session, which is Cause and Effect, an Introduction to Epidemiology. And we're joined today by Dr. Rebecca Venchiarutti, who is a Senior Research Fellow at Chris O'Brien Lifehouse, and she'll be talking to us about epidemiology. Next slide, please. So before we begin, I would like to acknowledge the traditional custodians of the lands and the waters where we work and live. I'm coming to you from Dharawal country today. We acknowledge the traditional custodians' living culture, their connection to country, and their contribution to the life of our regions where we all are. We pay our respects to the ancestors and elders of these regions and to all Aboriginal people, past, present, and future, and extend this respect to any Aboriginal people joining us today. Next slide, please. We would also like to acknowledge the support of the University Centre for Rural Health from the Northern Rivers as they are supporting the delivery and operations of our CLaN seminars. So who are we? Those of us who regularly attend CLaN may have been expecting some different faces. Zoe and Alex from Northern New South Wales are both on leave. So I'm Kimberly from New South Wales Ambulance and I'll be hosting or facilitating today's session. So CLaN is a collaborative between a range of local health districts and health services across New South Wales and Queensland. We've been going strong since 2023 and we look forward to bringing more research education to you throughout this year. We're also partnered by Hetty as well from New South Wales Health. Now, next slide, please. If you, for whatever reason, are not able to finish today's session or your colleagues weren't able to make it, for example, they're on clinical shifts, well, not to worry. All our recordings from all our sessions are on our YouTube channel, and this one will make its way there as well. So you can use that link or otherwise just Google CLaN YouTube and you'll be able to find it. Some housekeeping. So as I said, we're expecting a very large number, so we just ask everyone to keep themselves on mute. In order to facilitate the session as well, we would ask people to keep their questions to the end. You can put questions in the chat and I'll be moderating that as we go through. If there is something that I think is super urgent and maybe we do need to stop Rebecca, I'll interject, but otherwise we'll let her finish the presentation just to make sure this doesn't get too unwieldy, but we will have time definitely for questions later. Also, please note, we are, of course, recording this. So if you're uncomfortable with that, you just keep your camera off so you can't be identified in the recording. So questions, as I said, we're going to ask for questions to stay at the end, but that doesn't mean you can't ask questions. We will encourage some open questions at the end. If there's things that I can answer, for example, in the chat as we go, I'll do so. Otherwise, I'll keep a log and maybe ask some of those directly to Rebecca at the end when she's finished her presentation. Next slide, please. So an introduction to Rebecca. So Dr. Venchiarutti is a Senior Research Fellow at the Chris O'Brien Lifehouse and an Honorary Senior Lecturer in Clinical Epidemiology at the University of Sydney. She's a health services researcher whose work focuses on improving access to cancer services, optimising patient outcomes, and addressing variations in practice. She currently leads the research stream within the Head and Neck Rural Access Program at Chris O'Brien Lifehouse, a comprehensive cancer centre in Sydney. I've also personally had the privilege of working with her on a few projects and can attest to the fact that she's an awesome human being. So without further ado, I'm going to stop talking and hand over to Rebecca. Cause and Effect, an Introduction to Epidemiology. Thanks, Rebecca.
Thanks, Kimberly, for the kind words, and right back at you. So thank you, everyone. I'm really delighted to be here and presenting on something that I really love and really enjoy, which is epidemiology. I think from a kid who really loved doing puzzles as a child and sort of looking for patterns and that sort of thing, it's sort of my opportunity to do it as a career, which is quite nice. So I would like to add my acknowledgement of country as well. So I'd like to acknowledge the traditional owners of the land on which we meet today. I'm joining from the Gadigal lands of the Eora Nation here in Sydney, and would like to pay my respects to elders past, present and emerging, and pay my respects to any Aboriginal or Torres Strait Islander peoples here today. And if it's not too distracting, maybe let us know where you're joining from. It's always really nice to see. So a bit of an overview. As Kimberly said, we can do questions at the end, but I've sort of broken this up into 4 kind of sections. So maybe sort of after we get to the end of section 2, if there's sort of some really burning questions, then that might be an opportunity to kind of stop there. But I've broken it up into 4 sections, which I hope will give a really high level overview of epidemiology. So starting with some epidemiological principles and terminology, then moving on to bias and confounding, which are super important principles. I'll go into a little bit of detail and share some examples of some epidemiological studies. And lastly, just a quick touch on critical appraisal at the very end. Right, so what is epidemiology? So it's the science and practice that describes and explains disease patterns in populations. And I really love this definition. It's from one of my favorite textbooks, because I've got favorite textbooks, by Raj Bhopal from 2016. And I really like this because it's not too restrictive. The thing about epidemiology is it really is just looking at patterns in what we see and looking at cause and effect. And I like that we're not sort of hamstrung to a certain population. We're not looking at specific outcomes here. I guess in terms of health, we're looking at patterns of ill health and disease generally in populations. And we can systematically analyze these to understand what causes them and what we can change or hopefully fix to improve health. And how do we use epidemiology? As I've sort of alluded to, epidemiology is actually a really, really broad discipline. So there's cancer epidemiology, social epidemiology, environmental epidemiology, lots and lots of different sort of types of epi. But it kind of shows that we can use it in many, many different ways. So understanding what causes or sustains disease in populations. Measuring disease burden. So we might know that X amount of people will develop a certain type of cancer in their lifetime, but what does that mean down the line? What impact does it have on quality of life and their ability to return to work and be part of, our society? We can use epidemiology to assess the effectiveness of interventions. So we might initially kind of think about randomized control trials, which are one of the sort of essential study designs that we use in EPI, but looking at things like rolling out vaccines, rolling out screening programs, we measure that as well with EPI. We can prevent and control disease in populations. And I will just say COVID-19 was a really good example. Lots of people learnt what epidemiology was because of COVID, and I'll leave it there. But related to that, I suppose, is also we use epidemiology to guide health and healthcare policy and planning. So it doesn't end when you've done your study and you find out what the incidence of a disease is or what the risk factors mean. We actually use it to plan really important healthcare policy. And lastly, more of the clinical epidemiology side of things, it helps assist in the management of people who have certain diseases. So I know many of the people on the call will be clinicians. So you might have a really gnarly clinical question that you need an answer to for a patient that's sitting right in front of you. And being able to find the right study that will answer your question and critically appraise it using some of the skills that I'll present here today is really important. And I always love putting a little bit of history in. So not necessarily the first ever use of epidemiology, but probably the most famous was John Snow and the Broad Street water pump back in 1854 in London. So at the time, cholera was thought to be spread by polluted air, and many people were dying in London and other places because of cholera. So John Snow went ahead and observed what was happening. He observed the houses where people were living and who caught cholera, and he mapped them out. And so it's very tiny, but some of those darker sort of rectangles and squares in there represent cases of cholera at certain buildings. And by doing this, he helped narrow down on the source. So what was actually the common denominator? It was this water pump. He then, after measuring and observing, he implemented an intervention. So he removed the handle on the pump, people stopped using it, and the outbreak ended. So one of the sort of classic stories of epidemiology, very simple, but very effective. So a couple of principles I wanted to sort of get across, because I'll be using some of these terms throughout. We always talk about populations and samples in epidemiology, and sometimes maybe inadvertently they get mixed up. But a population is, I guess by definition, the whole group that you want to study or make conclusions about. And when we are defining our population, we want to do it in terms of time, place, and person factors. So, for example, if we were interested in looking into the problem of the rising incidence of colorectal cancer in young people, our population for which we want to make conclusions about and study would be people who are aged less than 50 years old who were diagnosed with colorectal cancer. And we put it sort of, we time bound it. So from the 1st of January to the 31st of December 2025 in New South Wales. So that might be how we define our population. It could go even further. It could go Australia-wide. It could go around the world. But it's the population that you want to be able to make conclusions about. So if we were going to collect data on the population, we would need to collect data on everyone. The problem is that's really hard. For a number of reasons, and anyone who's done any sort of data collection for a study knows how difficult that can be. So what do? We collect a sample. So the sample is a smaller and ideally a representative group drawn from the population that we can collect data on, we can include in our study to gain insight about the population, which we in a lot of cases can't really measure. So in this case, going back, we might have wanted to address every single cross in there, but because it's expensive to do studies, it's difficult to recruit everyone, we would go ahead and collect a sample, and we want it, as I said, to be representative. So we would want to make sure that we have a good distribution of important characteristics like age, gender, perhaps ethnicity, characteristics that we know are important to our research question. And we want to make sure that we collect people who have those characteristics to ensure the conclusions that we draw about our sample can then be generalized to our larger population. So that's populations and samples. The other principle is exposure and outcome. And I've used in the title cause and effect, but typically we'll sort of talk about exposure and outcome in epi studies. So the exposure, or in some cases it's a risk factor, is a factor that can be associated with our outcome of interest. It's as simple as that. Our outcome is an event or a state of health that we observe in a population. And we can make it as simple as having our risk factor or exposure be smoking and our outcome be lung cancer. It could be HPV vaccination, which is the exposure, and cervical cancer, which is the outcome. Or it could be something like a mindfulness intervention with quality of life as our outcome. So this is sort of our exposure outcome relationship, the sort of core relationship that we want to study. recognizing, of course, and I'll touch on this a bit later, many, many other things are interacting with the exposure and the outcome. But down at the core, this is what we want to focus on in the study that we do. The last kind of pair of concepts are incidence and prevalence. And these are kind of the bread and butter measures that we use in epidemiology. And if we know how to calculate incidence and prevalence, then we can go on to calculate all the many, many other types of measures, risk ratios, odds ratios, age standardized incidence. So kind of understanding these will give you a really good sort of baseline and sort of allow you to sort of, you know, find out more and use other types of measures as fits the needs of your study. So incidence is really just the count of new cases of a disease over a period of time in a population of known size and defined by certain parameters. So I typically go back to examples of cancer because that's a field that I work in. But if we talk about the incidence of oral cancer is rising in the population, that is telling us that the number of new cases diagnosed, say, per year is increasing each year. And so that's sort of an absolute measure, so just the number, but we can do things like age standardize, so we can get, you know, a number per 100,000, and I'll show that on the next slide. But the key thing here is that incidence is about the number of new cases that we see in a period of time. Prevalence is slightly different, where we're counting both the new and the old cases at a point in time. And again, I've got an example on a following slide. So it's all cases divided by the population at risk, whereas incidence is just the new cases. So I'll show you what incidence looks like. So this is Cancer Australia do some really fabulous data visualization, and I would encourage anyone to go and have a play, because there's lots of different measures that you can look at for, you know, cancer in this case. Really, really good. So what this graph is showing here is change in incidence of colorectal cancer in the entire Australian population over time. So these bits, these bars in the blue, are the actual number of cases of colorectal cancer per year. So back in 1983, it was probably about 7,000 cases diagnosed each year. We go all the way to 2021, we're looking at just shy of 15,000 new cases per year. As I said before, that's it's just an absolute measure. So it's just the number of cases that we're looking at. The other thing that we can do is age standardize, and I won't go into the detail about that, but really what that allows us to do is look at it, look at the incidence in different age groups, and there's different numbers of people in each of the age groups. So it just gives us a little bit more information about what's happening. And you can see this age standardized rate, so we report this as per 100,000 people, even though the absolute number of cases is going up each year, that's probably also because our population's increasing, isn't it? So we can actually see the age standardized rate is decreasing over time, and that decrease seemed to start sort of happening, you know, in earnest around 2011. So it's going down, 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 and these orange bars and points are projections. So in 2020, there were just shy of 15,000 new cases of colorectal cancer, but the age standardized rate, age standardized incidence, was about 59 cases per 100,000 people. So that's incidence. Prevalence, as I said, accounts for both the new and the old cases. So what that means, and they actually put it quite nicely here down the bottom. So 56,200 people were alive at the end of 2020 who had been diagnosed with colorectal cancer between 2016 and 2020. So there's a couple of really important points in there, and they talk about an age standardized rate as well. The first thing is we're looking at the number of people who are alive. So if a person passes away, then they sort of fall out of this number. So if you think about it in terms of a bathtub, we've got our incidence, the number of new cases, that's sort of filling up from the tap into the water. And kind of in the plug are people leaving the prevalence, the prevalence of the disease because they pass away. So it's the number of people who are alive, and it's kind of a nice way to summarize the burden of a disease. So even though people may survive their cancer, which is fantastic, we know that 56,000 people are still living with the effects of cancer, and some of them may still have active cancer, some may have been cured, but this is a really good measure for us to know what the burden is at any point in time. And we can see that's also, even though the prevalence is going up, so the number of people is going up, the standardized rate is tracking down, which is good. So I'll move on to bias and confounding. And the thing that I learned quite early on in terms of bias is that you'll never have a study which is 100% clear of bias. The important thing is that we want to know what the risk of bias is in a study and sort of make conclusions accordingly. So bias causes us to make false or incorrect conclusions. And there's a lot of different types of bias that can be introduced. They all have different names, can be a bit confusing. I like to break it up into selection bias and information bias. So a couple of examples of selection bias. The first is population bias. So one of the really important things, kind of going back to what I said about our population and our sample, is we want to sample a group that represent the population so that we can make appropriate conclusions. Now, if we get a bit lazy or we perhaps don't have the resources that we need to conduct a study, we can end up recruiting a sample based on convenience about who walks through your door, who you think might be a good person to participate in the study. And that's going to cause us issues down the line. This happens a lot in clinical trials, in lots of studies actually, where we see actually the profile of people who are included in the study, trial or other type of study, really don't reflect the population. So oftentimes they're overwhelmingly Caucasian. And in many cases, there's biological differences which we need to know. And that's population bias and causing selection bias. The second is response bias, and this is kind of related. This is where it kind of gets a little bit muddy, but it's basically unequal participation. So a really good example is people who are super motivated or healthier may be more likely to take part, particularly if you've got an intervention that requires someone coming in 3 or 4 times a week to the hospital. That's going to kind of eliminate people who actually might really benefit from the intervention by virtue of the fact that they just can't get there. So that's response bias. Information bias is sort of about the data, more or less. So we can have measurement error, which is normal, but we should still try and mitigate it. So this can be caused by imprecise measurement. We might use different methods. If we were looking at whether or not someone had HPV, human papillomavirus, we would want to make sure that the methods that we're using to detect whether that HPV is present is consistent across all participants in our study. Because if it's not, if we're using a diagnostic test, which has different levels of sensitivity and specificity, then that can introduce bias into our study. Recall bias, sort of a really easy one to conceptualize, I think, because we all have trouble remembering events that happened a long time ago. But that can cause issues if we're, asking people about risk factors. So, people who might have smoked when they were, teenagers, how much did you smoke? It's really hard to quantify that retrospectively. We also have response bias down here, confusingly enough, but this is about people dropping out from our study and therefore information being taken away from our study. So if people drop out, if we have inadequate follow-up, we're not properly collecting data on those people. And lastly, treatment bias. And this is really important for clinical trials, randomized clinical trials, where the intervention is not equal. And this can happen because of lack of blinding in a study, and I'll get to that a little bit later. But if I'm a doctor and I know that my patient is on the intervention, the new fancy medication that I want to show really works and we need it funded, I might be more inclined to report data in a certain way that favors that. So that introduces some bias in there. So back to my sort of term of cause and effect before I go on to confounders. Nothing ever happens in isolation. So again, going back to what I was talking about, exposure and outcome, if we were looking at the question of whether HPV, we know HPV causes oropharynx cancer, which is sort of the back of your throat, but there's increasing interest into whether HPV also causes oral cancer, so cancers at the front of your mouth. We might design a study that is based around this, and we might measure HPV exposure and then whether or not they have oral cancer or whether or not people develop oral cancer. The thing is, nothing happens in isolation. So whether or not you have HPV can depend on your gender, how many sexual partners you've had, your sexual behaviors, your age, and then of course, oral cancer. We know tobacco and alcohol cause oral cancer. So these are where we need to start thinking about confounders, these other factors that are happening around our main exposure outcome relationship that could potentially shade or blur what we're seeing. So confounding happens when we compare populations which differ from each other and can lead to false interpretation of what we see. So I'll work through a little bit of an example with this. So we might have done a study that showed that people who drink alcohol have an increased risk of lung cancer. So we need to kind of think through how this might happen. It might be rather unexpected. A potential reason for this, a possible explanation, could be that alcohol and smoking could go hand in hand. If you smoke, you might be drinking. If you drink, you might be more inclined to smoke. So smoking may actually be the real driver of the association that we're seeing, sort of being the association is kind of showing up because actually smoking is acting in the background. So here the confounded factor is alcohol. It's being confounded by smoking. So what we need to do is we need to see if this alcohol lung cancer association still holds in people who are not exposed to tobacco. And this is kind of where we get to sort of controlling and adjusting, which I won't go into in this. If we do find that after we look at people who have not been exposed to tobacco, that alcohol and lung cancer, that association still holds, then tobacco is not the confounder, and we need to think whether there's something else that we've missed out on. So I said I would briefly stop there. Kimberly, you haven't jumped in yet, so should I keep going?
They're all really quiet. No.
Oh,
no one's answering anything or asking anything in the chat. So we might just press on.
Yeah, sure. I hope you've got like a cup of tea and a biscuit and you're just sitting back and relaxing and can have a chat later.
Oh, hang on. Well, someone's just popped up. Actually, probably it is good if people want to jump in. So someone's just asked, Alexandra has asked, would love some ideas and ways to overcome the types of bias.
Yep. So it all comes down to, I might go back to the bias slide, so I've got it on there. It all comes down to really good study design. And that is also related to what's on the next slide, which is that graph about understanding how all the factors are kind of playing together. So it wouldn't make sense if we just measure the exposure and the outcome. We need to think about all the things that are kind of happening around the side. In the context of a clinical study, you know, I always put my hand up and say I'm not a clinician, I'm a pure researcher. I always have clinicians on my team who are advising me, you need to collect this, or we need to account for this. So I think teaming up with subject matter experts and reviewing the literature is super important before you go in and start designing a study. And that will actually kind of help address a lot of these, particularly with information bias, you know, imprecise measurement. Make sure, you know, if you're doing a pathology study, you team up with a pathologist to know exactly what you need to collect. But sometimes it's, if resourcing is an issue, and that might affect, you know, how you can recruit people, you might have to consider redesigning your study to answer the question in a slightly different way.
Yeah, thanks. We had another question around prevalence and incidence, but just a note for everyone, we will be circulating the slides later on. So some of these slides, if you want to, when you get them, you can have a mull over them and see if that's helpful as well. If we get some time later, we might come back to that one if that's all right.
Yeah, sounds good. Okay,
Alrighty.
should I move on?
Yeah, let's do that. Thanks everyone for
All
your
right.
questions.
Yeah. Sorry. Okay, so types of epidemiological studies. So a really nice way that I have seen to sort of classify studies is sort of, I think, 5 or 6 different characteristics. So is it descriptive? Are we just sort of telling the story about what we're seeing? We're sort of taking observations, or is it more analytic? Are we sort of testing something? Do we have a specific hypothesis that we want to test, you know, comparing 2 groups, for example? Is our study retrospective or prospective? So retrospective, we're going back in time. Prospective, a lot more time and resource consuming, but we're going forward in time and following people up. Is it just observational or is it experimental? So are we just observing what's happening in a sample or the population, or are we doing an intervention? Do we begin with the disease, or do we begin with the risk factor of disease? And this will make sense a little bit later when I present some of the epi studies, and whether or not a specific comparison group is needed in our study design, or whether we don't need one at all. So you may have also seen the evidence pyramid. So right at the very top are things like clinical practice guidelines, and they are sort of the gold standard that we should be using if we want to answer a clinical question, right? So ideally, you'll have a clinical practice guideline that you can go to for your patient, and you'll be able to know whether something works for them or what to do based on that. And that clinical practice guideline has been developed based on all of these studies kind of down the bottom. And the good news is someone else has appraised the evidence for you. So these are sort of our secondary or pre-appraised resources. Systematic review and meta-analysis falls into that as well. Further down, we've got primary studies like randomized control trials, cohort studies, which are my favorite, case control studies. So these are our primary research studies. And cohort studies and case control studies are our observational studies. Lower down, we've got study designs that studies that have no design, so case reports or case series, expert opinions, and finally sort of animal and lab studies which don't have humans involved. That's sort of once you start getting further up the pyramid. So I just wanted to make a really quick note that actually among these secondary and pre-appraised resources, there's actually kind of a sub-pyramid in there as well. And the reason is because often with a clinical question, we can get a really good answer from summaries that are already existing. So it's always really nice when there's a clinical question you have and you can go straight to the literature and you realize that the answer is there waiting for you. So some of these are subscription based. So, Up to Date is available through hospitals and health systems, which is really fantastic. The other one I really like is the TRIP database. So the TRIP database will allow you to put in your clinical question. So it might be aspirin for, prevention of colorectal cancer. And it will give you a whole bunch of resources, and it will actually tell you where on the evidence pyramid they sit. So whether they're sort of way down the bottom in these sort of individual sort of primary studies, maybe a case control study, or whether there's actually a clinical practice guideline, which is ideal, which will tell you whether you should recommend aspirin for the person that's sitting in front of you. So I just wanted to sort of almost sidebar there to talk about these because they're super useful, and the hard work is kind of done for you. However, if you're keen to get your hands dirty and do some studies yourself, I highly recommend it. So I'm going to go through each of these sort of bit by bit and provide an example there for you, just to sort of go up the evidence pyramid, except for clinical practice guidelines. So we might start kind of down the bottom with a case series. So case series are, even though they're down the bottom, they can be really important in epidemiology. In this, we're really just counting the number of cases of a disease of interest, and we're relating, and we relate it to population data to produce rates and analyze patterns. So we can do this with a clinical case series. So that might be, patients that a doctor sees in their own practice, or it can be a population case series. So, things like registers, and they're often for, uncommon or sort of rare conditions or events. So case series are purely descriptive. They are retrospective. They are observational. They begin with a disease of interest. So everyone kind of has to have the disease to be in the case series. And then you don't need a comparison group in that either. So a nice little example, again, with the COVID-19 influence, is this study, which is a case series of children with COVID-19 infection, and they describe the clinical and epidemiological features. So if you notice the date, this was published on the 28th of February 2020. And I think that really highlights the importance of case series in epidemiology, because it allows you to kind of get things out fairly quickly, give people a sense of what's going on. In this case, and not expecting anyone to sort of read this in detail, but along the top, actually, I don't know if you can see my cursor, but they've got patient 1, patient 2, patient 3. So the information is reported separately for each patient or participant. But the level of detail they have is sort of extraordinary, right? So they've got the admission date, the city where they're admitted, a whole bunch of information about their exposure, how long between symptom onset and the exposure to the index case, for example. So it's really rich in detail. And, this is a really good example of how we can use case series. So even though they're down the bottom, they do have a really important role. So next, as we're moving up the pyramid, are case control studies. And I will always put up my hand and say, I've never done a case control study. So really interested to do one. But in essence, we're looking for differences or similarities between people who have a disease or condition and those who don't. I promise you I won't go into things like odds ratios and maths and stats, but case control studies report the results in terms of odds ratios. So the odds of something happening in one group versus the other. So the characteristics of these, they are more analytic instead of just descriptive. They are retrospective. They're observational, so there's no intervention that we're doing. You start with the disease of interest, so our cases are defined by the disease or condition, and you need the comparator. It's, I guess, in the name, isn't it? Case control studies. So this is just one example, and you know, no use kind of going into a lot of detail about it. But this is a study where they looked at the association between aspirin use and pancreatic cancer. So our cases were people who were diagnosed with pancreatic cancer. Our controls are randomly selected residents, so people in the general population who are free of the disease, so they don't have pancreatic cancer. The exposure that they measure is use of aspirin, and the outcome is pancreatic cancer. So what they do, what happens in a case control study is they start with their cases. So it might be a 50-year-old man with pancreatic cancer, and they try and find a control from the population, the general population who are disease-free, and match them based on their age and gender. This sort of matching can reduce the risk of confounding because of age and sex. We don't want to go too crazy with matching. So it can just make things very, very difficult, and it runs the risk of sort of missing some associations because causal factors have inadvertently been matched for. So matching on age and gender is entirely appropriate, and you collect information on the causal and mediating and confounding and effect modifying factors. So to see whether that association, exposure to aspirin, leads to an outcome of pancreatic cancer. So that's case control studies. Cross-sectional studies are kind of within this kind of cohort study. They're not a cohort study. They're not sort of happening over time. They're at a defined period of time, but they kind of sit around here. So I just pop them in there. In a cross-sectional study, we study the health and disease states in a population at a defined place and time, or we can use them to measure burden of disease. So these studies are descriptive, they are retrospective, they're observational. You can start with the risk factor or disease kind of simultaneously, and you don't need a comparison group in these. So the important thing about cross-sectional studies is they should be quite geographically defined and represent the population as much as possible. So we sort of narrow it down to time and space. So it wouldn't make sense if we did a cross-sectional study that recruited patients or got them to do a survey over a year, because so many things change, sort of seasonal variations, all sorts of things. So we're taking a sample of the population at kind of a narrow-ish point in time. It might be recruit over a couple of weeks or a month. So if we assume that the sample is representative of the general population, then the results can be generalizable. So a nice example was a study published back in 2020 from the English National Cancer Diagnosis Audit. So this is using primary care data. This is a cross-sectional study. And they just wanted to know what was the prevalence of 11 pre-existing morbidities in people diagnosed with cancer. So they looked at people with 29 types of cancers. So here they report on the prevalence of each morbidity by cancer type. So they look at the observed prevalence, so kind of the sort of crude or absolute prevalence, and then they age and sex standardize it, because we know that the risk of some morbidities changes by age and sex. So when we standardize for that, we get something that's a little bit more nuanced. So how do they report it? So just in this table here, so they had 14,774 cases, patients in this sample. 5,752, for example, had hypertension. So that's an observed prevalence of 39%. So 4 in 10 people had hypertension. When they standardise it by age and sex, it goes down to about 24%. And they've done that for all the different morbidities they looked at. And then they also report the specific morbidities, in this case, respiratory disease in this graph here. And they look at the proportion of people, the prevalence, with respiratory disease by cancer type. So unsurprisingly, people with lung cancer have a much higher prevalence of respiratory disease than most of the other cancers. So that's happening at one kind of point in time, more or less. Cohort studies, as I said, are my favourite. In these ones, we follow up populations and we relate information on risk factor patterns and health states at baseline to the outcome of interest. In contrast to case control studies, we report here in terms of relative risk or incidence, generally not odds ratios. That's a whole nother story. But the characteristics of cohort studies are that they are analytic. They can be prospective or retrospective. They're observational. And you usually start with the risk factor. And you generally need a comparison group in these studies. So a nice example of a retrospective cohort study, and retrospective cohort studies tend to get a bad rap. I mean, they're not the highest level of evidence, but they're really good because they're really accessible. And if you collect data that you know is reliable, for example, you know, in your medical records system, then you can do a pretty strong retrospective cohort study, and that's a really good place to start. So in this study, they looked at people who were hospitalized who also had COVID-19. They wanted to know whether the exposure, being diabetes and hypoglycemia, was associated with death, ICU admission, and length of stay. So in collecting information about people who were hospitalized with COVID-19, they had two groups, people with diabetes and people who didn't. So that's our comparators in this. And they looked at these two groups and said, okay, how many people died, how many were admitted to ICU, and how long were these people staying? So they found that neither diabetes or hypoglycemia predicted death independently. However, admission glucose level, but not diabetes, independently predicted ICU admission and length of stay. And I've purposely sort of mentioned independently, because if we remember back to our confounders, there's lots of other things that can sort of lead to the outcome, right? And lots of other things that can influence the exposure of diabetes, which could also lead to the outcome. So what they've done is adjusted for these confounders in their study so that they can say, well, based on all the things we collected, knowing that there are some things we can't collect, we know that neither diabetes or hypoglycemia predict death, but glucose level is able to predict ICU admission and length of stay. Prospective cohort studies are fantastic, and you may be aware of some sort of landmark studies. So in prospective cohort studies, people are recruited generally from the general population, and they're invited to be part of a long-term study, or it could be that they have the disease of interest or a risk factor, and they're followed up over time. Some of the really landmark ones are the Framingham Heart Study and the Nurses Health Study from the US. And here in Australia, we've got the Australian Longitudinal Study on Women's Health. So that was established all the way in 1996, and they've got 3 cohorts of participants that have been recruited. So that's based on their birth year. And as I said, people recruit, these are examples of where people are recruited from the general population and monitored regularly over time. I'm going to speed up because I know we've got 10 minutes left. I want to leave time for questions. So I'll kind of skip this, but essentially very similar to the retrospective cohort study. You've got your population exposure and your outcomes, and you look at people who are exposed and unexposed. Lastly, something most people would be very familiar with are trials. So we use trials to test an intervention. That's designed to hopefully improve health, and then follow up to see the effect. So these are analytic, they're prospective. For the first time, we've got an experimental study. And usually we start with a disease, people who have a condition, and you need a comparison group. Randomized control trials, in particular, there's lots of different types of trials, but randomized control trials really need to have random assignment of groups. And this ensures the groups are equal at baseline and minimizes confounding, because that means that the only difference between the groups when we look at the characteristics should more or less be one had the intervention and one didn't. So all the other characteristics should randomly be floating around, and it should be more or less even. We want allocation concealment because we don't want someone who has a piece of paper in an envelope holding it up to the light, knowing that Joe Blow is going to be allocated to group B next, but I actually want him to be allocated to group A, so I'm going to switch around. So we want proper concealment, ideally with a computer. Blinding. As many people as possible should remain unaware of the group the participant is in. It's not always possible, it's not always ethical, but that will help minimize bias. And analysis, there's lots of things that could be said on that, but ideally we want to retain the randomization if possible. Sometimes people cross over, which can cause issues, and there's ways around that, but ideally analysing the groups they're allocated to. And just an example here about a study done in an ICU with people who have proven or suspected infection. They were randomized to receive vitamin C or a placebo every 6 hours up to 96 hours. And they have a composite outcome of either death or persistent organ failure on day 23. So probably the one that a lot of people will be quite familiar with is randomized control trials. So I'll spend a couple of minutes before I finish on critical appraisal. It kind of brings together, critical appraisal really brings together everything that we've kind of talked about, right? So the purpose is to evaluate whether the study is valid, if it's reliable, should be trusted, and if it's relevant to a particular context and your context that you're working in. There are lots of different tools that we can use, and they usually depend on the purpose of why we're doing a critical appraisal. So are we doing it because we've got a journal club and we want to, you know, pick it apart and really kind of go into it? Or is it they differ because of study designs? So a couple of examples of risk of bias there, but I will pretty much wrap up by saying these are a couple of my favorite. The Critical Appraisal Skills Program, they're free downloadable checklists for different study types, and the Joanna Briggs Institute as well. But really, we want to think about, was the study designed properly? So how were participants recruited? How were the data collected or measured? Is the analysis appropriate? What are the sources of bias, and have all the confounders been identified? Have the results been reported appropriately? And really importantly, can the results be applied to your research question? If it's done in a completely different context, it's not really going to mean much to you. So just something to think about with critical appraisal, but please do go to those resources and they'll be in the slides that we send out. So I will wrap up there, and please shoot any questions at me, and if I can't answer them, then I will find out for you. Thank you.
Thanks, Rebecca. That's fantastic, and I think a really helpful overview of this area. I love looking at the screen. There's always clapping hands and thumbs up emojis. So I think there's a great consensus, which is just beautiful. And there's been some lovely comments as well. There's been a few questions come up in the chat, but I can see someone has their hand up. No, the hand's gone down. Alrighty. So I think we talked about reviewing prevalence versus incidence. So we'll circulate those slides, which might help explain. Someone had a question on if we could get your general thoughts on power calculations and the types of studies that might be useful for. I'm just throwing a statsy question at you.
So so that's a statsy question, and very basically, I would always speak to a statistician before you do your study. And the reason we do a power calculation is we want to know if we basically want to know how many people we need to recruit to be confident that we're going to see a difference in an outcome if it exists, right? So it varies based on the study that you need to do. So whether it's a case control study or whether you need you're doing a cohort study or a trial. So people talk all the time about my study wasn't powered to answer that question. You can kind of go back retrospectively and figure out actually what the power was for your study. But if it's really good just to limit yourself, I will say, to one main question you want to answer and power your study based on that. Don't worry too much about all these secondary outcomes, but power your study based on that primary outcome, and speak to a statistician.
Yeah, absolutely. Getting that advice in the first instance, and not getting so far down the track that you realize that things are a problem, trying to speak to the relevant experts, certainly earlier. And I also advocate for a simpler design, where possible, focus on a couple of things, one or two things, rather than trying to answer everything. And we had a question around risk versus odds ratios in cohort studies, and perhaps why relative rather than odds ratios.
So is that can you point to any literature? Was that the question?
Yeah, that one. Yeah. And I said,
I can definitely include some papers. So, I mean, not to overwhelm people. So relative risk that we use in our cohort studies is kind of like, so essentially what we do is we're reporting the risk of a disease for one group, which is the one with the risk factor, say, to the risk in the group without the risk factor. So there's a lot of times I've used the word risk in there, and that's why we use the term relative in there, because we want to know what the risk is for group A relative to group B. And it's kind of a measure of the size of the effect of the risk factor. And so it's kind of the strength of the association. The odds ratio, we kind of see, as I understand it, sometimes the odds ratio can approximate the relative risk, which is why sometimes it's used. And a lot of statistical programs will report it when you do something like a regression analysis. But it's basically one set of odds. So the odds of the event for one group divided by the odds for the other group. And I don't know, I think if I keep talking, I'll confuse myself and other people, but I'll find something that's digestible that I can send around.
Thank you. Yeah, maybe we'll include that with the session slides when we send them around. In the last minute, perhaps, we've had a question around methods which demonstrate causality in a robust manner. And I think probably maybe which of the study designs I think is probably meant to demonstrate causality in a robust manner.
Funnily enough, I was having a conversation about this with a colleague because we were talking about the rise in oral cancer in young women. And there's been a few sort of cohort studies, retrospective cohort studies that have been done. But one of the things that we're really missing is actually a case control study. And it is really hard to determine causality, funnily enough. And that could be a whole nother lecture, couldn't it?
Well, it's correlation does not equal causality, right?
Yes. Yeah, it does not. Yeah. And so sometimes a nice simple case control study can be good to demonstrate that. But it also comes down to the design of whatever study you're doing, of trying to collect all the appropriate information to answer your question as well. So yes, case control studies can be good for that, because you're going back and kind of looking at the risk factor. Okay.
Right. Yeah. Thank you. And maybe can we just skip to the couple of next slides? So our next session next month is being delivered by Professor Andrew Bailey. You can scan the QR code to register, but congratulations, if you've registered for this session, you're now on our mailing list. So you'll get sent some information anyway. So Andrew is going to unpack how we measure things. So that will be really exciting. We also love feedback here at CLaN. So the next slide has a QR code on it, and I've also popped the link in the chat. We'd love to hear what you think about our sessions. So if you've got a couple of minutes to spare, we'd love you to complete the survey. As I said, there's a QR code or there's a link in the chat. Otherwise, in the interest of time, I might wrap us up here. Maybe Rebecca and I can hang around for another couple of minutes, but we'll stop the recording. And I'd like to officially thank Rebecca for her time and explaining all these concepts to us. I think it's been a fantastic presentation. I think everyone's really valued it. So thank you very, very much.
Thanks, my pleasure.